Okay, so I'm going to now shift and tell you, my accident trip into entrepreneurship. And what I'm showing you here is a picture that was taken in 2004, and I'm holding a vial that contains a drug that was designed in my lab that is identical to the one that was given eventually to about 1,000 patients. I'm a PhD protein chemist, never really intended to develop drugs. And so if you understand better my past, you will understand why I'm passionate about translational research. So it started when I took 3 months sabbatical in Italy. In fact, next week on Wednesday, I'm going for my next 3 months sabbatical in Italy. So hopefully that will be as productive as this one. I was in an NMR lab with a huge magnet sitting in a church, honest to God. And I was looking at the structure of a protein called protein kinase C delta, for which the structure was not solved then, and in fact is not solved even now. And I was looking at a particular domain that led me, and again, it's too long a story to tell you, to identify a short sequence in this peptide, in this protein, this 7 amino acid peptide, that I thought will be selective inhibitor for this enzyme that does not work on the catalytic activity, but actually on something that it's selectively doing when it's interacting with a partner protein. So, we're talking 98. So you used to dial to get to the internet, and I dialed, and I gave the sequence information to the lab in August. And in September, when I came back, they already have in vitro data in cells showing that this peptide actually works as we hoped and has high selectivity. And then when we started to think about what will be the next step, and again, here the story is a bit longer, but I'm shortening it, we moved to various animal models to show that the peptide is actually efficacious. And actually, importantly, the reason why we moved to cell and then to animals is because nobody cared otherwise. So I wasn't thinking of curing anything. I just wanted to do something that will prove that this matters, that this inhibition of the enzymes through this area that is not the business end of the enzyme is really important physiologically. So we started with monitoring how this peptide affects heart rate, which I later was told that is really not important clinical indication. And then, and then through help of physicians that joined my lab, we started to work on heart attack. Importantly, the peptide was shown not only in my lab, but in the lab of people said that they don't believe it, that to inhibit infarct size in these animal models, in mice and rats. We wrote papers about it, we wrote patents about it, and got zero interest from industry. And then I talked to some cardiologists here, including, by the way, Paul Yock when he was still an interventional cardiologist. And they gave us another idea. They say, rodents are really not, human heart is a bit different. It's not the best model. Why won't you work with pigs? OK, so this is expensive way of doing research, but it turned out to be rather important. So we use the same balloon catheter that is used to open up occlusion in the artery. But we caused the heart attack in these pigs. And the way we did it, we inflated the balloon in this position, and we left it inflated so it will cause ischemia or heart attack in this territory that is fed by the artery that is going down here. And if you hold it inflated for a long time, you get an infarct size whose size you can control. So we try to get something that will occur in humans after about 3 or 4 hours of heart attack. Then there was a big question of when should we deliver the drug and for how long. And initially, we started to deliver the drug before and after heart attack, but recognizing most patients, unfortunately, don't know when they will have a heart attack, we decided to start and doing it right after heart attack. And then there was a negotiation of how long we can deliver the drug, because the idea was that we will deliver it through the guide catheter after we remove the guide wire, for those of you who understand it. So what we do is we deliver the drug locally right to the territory that was ischemic. So the question is, how long was acceptable time? Because if you think about the procedure, patient gets a balloon catheter, they inflate to squish the clot, and then they deflate as soon as possible, and they move out. So the question is, how long are you willing to hold the balloon inflated? So initially, I asked for 10 minutes. They said, absolutely not. So how long will be acceptable? So they started to talk about 5 minutes and so on. I said, let's try 1 minute and see if that works. 1 minute will work for the cardiologist. The agreement was yes. So we delivered it for 1 minute, and then we checked 2 things. How well the heart is working, and what is the infarct size. And the way we determined then infarct size was actually to harvest the animal and cut the heart and look at the area that was a territory for infarction, which is a red area, and white where there was infarction. So let's start with infarction. And here is a change in infarct size. 1 minute of this drug at a dose that was 250 nanogram of drug per kilo caused a 70% reduction in infarct size. Huge effect. In fact, I always do studies in my lab in a blinded fashion. In this case, we had to cover the screen so that the physician will not know, the interventional cardiologist that did the treatment will not look at what the screen shows them, so that they will not be unblinded. We look also at cardiac function. And we started with about 40 animals per each group. And you see that the number goes down. That's because we had to harvest the animals to see the infarct size. OK, so here are the control animals. And you look at what is called ejection fraction. So the PhD among you, like me, ejection fraction is simply a number that shows how much of the volume of the left ventricle is squeezed out in each heartbeat. Pigs, as human, it's around 65%. And you see that immediately after infarction, the average ejection fraction goes to down to 40%. After a day, it starts to creep up. And by 10 days, it stabilizes. And the ejection fraction is around 50%. And if these pigs were human, you would send them home with drugs that will prevent deterioration to heart failure, which include beta blocker, ACE inhibitor, angiotensin receptor blocker, and on stuff. You worry about this patient going downhill. So here are the ones that got the delta PKC inhibitor. We started with the same ejection fraction because, of course, they are the same groups of pigs. They are litter mate. And then immediately after infarction, we saw that the ejection fraction was much better. In fact, it was as good as it would ever get in the animals that got control treatment. And by 5 days, it was normal. And at 10 days, it remained normal. And 14 days, I guess, that's how far we waited. So giving this drug after heart attack was particularly beneficial. This work was done by 2 postdocs in my lab, one interventional cardiologist, one cardiologist. And they told me that if they have heart attacks, they first go to the lab, and then they will go to the emergency room. That was important because they are the one who sees their patients. So I was very encouraged, and I thought, OK, now pharma will be interested. But that was not the case.